Thank you for the introduction. So for therapeutic interventions such as TAE, the endpoints for these are really qualitative and they rely a lot on the macroscopic flow. And so one intervention is a transarterial embolization, which is shown here. And what we do for that is we navigate a catheter through the arterial system, so to a desired location. In this case, we're looking at the liver. So it would be like the left or right hepatic artery. And then we would deliver these embolic agents and block off the blood supply. And now what this does is this causes necrosis and ischemia, effectively treating a tumor or unhealthy tissue. So this is great for hepatocellular carcinoma, especially because of the dual blood supply in the liver. So these tumors are really greedy and get a majority of their blood supply from the arterial side. And so we can kind of selectively treat them while still supplying the rest of the liver from the portal venous system, which gives about 90% of the blood supply to the rest of the tumor. So it saves a lot of the background. And the effectiveness really of these treatments relies on the level that we embolize to. So you can imagine if we under-embolize, then we might need further interventions such as radioembolization or chemoembolization. And if we over-embolize, then we're starting to really affect the healthy tissue, causing liver toxicity to increase, as well as maybe accelerate liver failure, which would not be wanted. And so really these endpoints right now are very subjective. One technique that is used to kind of monitor this is DSA. So this is showing kind of a pre-image treatment and a post-image. And so it really relies on the radiographer's eyes to kind of determine when the stasis is at an adequate level for them. So what we hypothesized was that 40 flow MRI could really provide some quantitative parameters to this before and after TAE. We think that before this could really add some like baseline flows, kind of predicting where we should treat from, maybe selecting vessels beforehand. And after we can look at how effective or how like maybe start quantifying percentages of embolization that we've achieved in these cases. So kind of just give an overview of our procedures. We had a clinical intervention where we did a hepatic TAE in 5 swine, 4 on the left, 1 on the right. Primarily the liver and the pigs are left dominant, so we chose the larger branch that fed more of the liver. These were all female pigs, and the embolization we completed was the radiographer's choice. So we had 2 at complete stasis and then 1 at partial stasis. And the embolization was with 100 and 300 microspheres. So in the pilot study, we looked at both pre and post embolization. What we monitored for pre was the conservation of flow in the hepatic system. And then post, we looked at kind of these velocity changes before and after the treatment. And so what we wanted to look at with 40 flow MRI is how well can we resolve the vascular anatomy both before and after intervention, as well as the quantitative information we could provide. And for these, we had large field of views, which you'll see. And we validated this with inline ultrasound flow wire, which we fed through the catheter to the specific locations. So this is kind of our outline. And the step 1, I guess step 0 is me packing like my breakfast, lunch, and dinner in a bag because I'm going to be there forever for these treatments. We go to the MR early in the morning, we load up the swine, and we complete our 40 flow processing. Then we transfer this swine to the embolization suite, where we set them up, navigate to the common hepatic, record our ultrasound measure, then navigate to the branch that we want to embolize, which is either the left or right hepatic. Then we complete the ultrasound measures as well there. We complete our embolization and then repeat the ultrasound measures, and then we transfer them back to MR, which takes around 20 minutes post-embolization to move them back from table to table, and then we repeat our 40 flow sequencing. And then after all that, I have to do all the post-processing, which takes hours on top of that. So here's some of our scan parameters. Our field of view is giant because we also wanted to get some renal information as well as capture the splenic and other arteries there. So some of the post-processing that we completed, we had first we create the magnitude, complex difference, and velocity vector maps. And then for segmentation, we do this on the complex difference using a semi-automatic segmentation, which would be just region growing or automatic region growing for that, and then making sure that it's not super noisy or we're missing vessels. We place the analysis planes off those angiograms by using Insight, and then we export these manual planes and manually placed planes and then do manual vessel segmentation and a customized MATLAB software. For the ultrasound system, it's a Volcano US or ultrasound system, which it's kind of hard to find details on it, but the wire essentially you feed through the catheter and then you can get like at 5,000 hertz output of instantaneous velocity and average velocities. So we smooth that data and then remove some outliers and then do an averaging over multiple heartbeats. So we usually record about 10 cardiac cycles for that. So just to kind of localize you on the vessels that we're looking at, we first have the aorta coming down to the celiac, which branches to the splenic and hepatic arteries. We look at the hepatic, we have the gastroduodenal, right and left hepatic arteries, and then those further can branch into the left and right lateral and medial branches. So kind of what we're looking at is surrounded by the red or orange box up there, mainly at the liver right now, but we also have data on kidney and the spleen as well. So to look at the first thing, we looked at conservation of flow in the hepatic system. So this is the average from all 5 swine that we had here. Looking just at the graphs, we have under 10%, so we have a fairly good conservation of flow for both the second order and first order branches. We couldn't resolve every branch with every swine. It depended on the size of the vasculature and also the speed of the velocities that were present. And again, this is just pre, because when we do post-embolization, some of the slows can get very, very slow. And so it's one of the interesting things, which is kind of more clinically relevant that we were looking at, is the changes before and after embolization. So for 3 of the swine, we were successful in completing the embolizations. In 2 of them, we acquired the data, but we had errors either in the pre or post data. So what's interesting is the first and third swine, so you can look at the common hepatic, it did a pretty much full stasis, so there was like a very small amount of flow, and they follow very similar trends, both with MR and ultrasound. In the partial embolization, there was about a half decrease, and what was really cool is we could actually still pick up the vessel that we embolized in, showing a similar decrease both with ultrasound and with MRI. So it's very great results to see that we can actually record this on MR as well. So in conclusion, we've successfully characterized embolization-related changes, both in the hepatic artery flow. We really think this can add some quantitative parameters to a subjective system. We really think, too, as well, like just planning and also kind of assessing when we've successfully embolized could be really impactful with this work. Some things we want to look at in the future is how well we can define kind of these embolization regions, and then correlating that to the effectiveness of the treatments, as well as increasing our sample size throughout these studies. So I'd like to thank all the people that have helped out with this and financial support. I can take any questions.